History of having antitubercular therapy for pulmonary TB 25 years back, and no history of diabetes mellitus, hypertension, cardiac history, bronchial asthma, thyroid dysfunction. Personal history: normal sleep and reduced appetite, normal bowel and bladder habits, smoker for past 45 years and smokes 1 packet per day, non-alcoholic and no addiction for pan chewing, no allergies for any drugs. Family history: no history of similar illness in any of the family members. Marital history: married at the age of 25 and having 2 sons. Coming to general examination: conscious oriented, examined after getting adequate consent from the patient and the bystander, examined in the lying position. His convulsive score was 100 out of 100. Pulse rate was 68 beats per minute, which was normal in rhythm, volume and character. No radial or radio femoral delay. BP was 110 bar 70. Then respiratory rate 18 beats per minute, SpO2 60%. Para was present, no icterus, clubbing, cyanosis, generalized lymphadenopathy or bilateral pedal edema. Coming to examination of abdomen: all quadrants were moving equally with respiration, umbilicus central and pushed downwards, no scar, dilated veins, hyperpigmentation of pus or sinus discharge, no visible peritals, no visible pulsation over the abdomen, no visible swelling noted in the abdomen, hernial orifices were normal, flanks were full. Coming to palpation: no local rise of temperature, no tenderness, 15 to 12 centimeter hemispherical swelling palpated extending from epigastrium, umbilicus, left hypochondrium and left lumbar area. Medially 5 centimeter below syphisternum in midline and laterally up to left mid-clavicular line, inferiorly up to umbilicus and superiorly up to the 12th rib, which was irregular in surface and firm in consistency with well-defined borders. In knee-elbow position, the swelling moves forward, and swelling does not move with respiration. Restricted mobility in horizontal direction and vertical mobility completely restricted. No other mass palpable in the abdomen, no guarding and rigidity, no abdominal distension, no free fluid in the abdomen, no tenderness in renal angle, no supraclavicular lymph nodes and axillary lymph nodes palpable, hernial orifices are normal. In percussion, impaired resonance felt at the mass and dullness over the upper border of the liver, resonant in renal angle, and no shifting dullness or no fluid through. Bowel sounds were present. Digital rectal examination: normal sphincter spasm, no blood staining or no bogey mass in the anterior side, no blummer shelf, and no fecal staining was present. Coming to other system: normal vesicular breath sounds and S1, S2 head normal and with no murmur, no focal neurological deficit, and skull and spine were normal. We come to a differential diagnosis: gastrointestinal stromal tumor, small intestine or stomach, or lymphoma stomach. Then we have done a complete blood count, which came to HB was 7 milligram per deciliter, and we have done a USG abdomen, which shows Curie GIST stomach or lymphoma stomach. Then we have done a CCT stomach, which showed irregular hydrogenously enhancing lesion arising from the greater curvature of distal body of stomach with anterior exophatic extension reaching up to the anterior abdominal wall, with multiple perigastric lymph nodes to consider the possibility of GIST, such as histopathological correlation. Also, it showed liver shows volume redistribution changes with minimal caudate lobe hypertrophy, such as LFT correlation and cholelithiasis. We have done an upper GI endoscopy, which shows esophageal candidiasis, antral neoplasm. And in microscopy, it showed multiple fragments of neoplasm lined by normal-looking gastric foveolar epithelium with extensive areas of ulceration. Round to irregular hyperchromatic nuclei seen as nest, sheet, trabeculae, and single-cell pattern infiltrating lamina propria and muscularis mucosa. Moderate nuclear ATP noted and extensive areas of necrosis, apoptotic debris, and crush artifact noted. Lamina propria shows moderate lymphoplasm cytic infiltrate. In antral biopsy, features were suggestive of purely differentiated neoplasm. Possibilities include small cell neuroendocrine carcinoma, purely differentiated adenocarcinoma, and non-Hodgkin's lymphoma. Then we planned for a IHC, which was sent from antral biopsy. That came, sample was inadequate for IHC. Then patient was suggested to repeat OGD biopsy for IHC study. Then patients and bystanders not willing for the same. Then we have prepared the patient. Other routine investigations were done, then correction of anemia by transferring 2-point PRBC, then correction of the nutritional status, and assessment of cardiac, respiratory, and renal status. Prophylactic antibiotics were given. We are planned for a staging laparoscopy and proceed, which showed no liver, peritoneal, or omental deposits or ascites. Ulcerated and necrosed large mass arising from the stomach was identified. Then we had done a midline laparotomy, which showed 15 into 15 centimeter mass arising from the body and antrum from both greater and lesser curvature with infiltration to transverse mesocolon. No metastasis to peritoneum, liver. No peritoneal deposits or ascites. Then underwent distal gastrectomy with gastrojejunectomy and jejunectomy with plus omentectomy plus excision of portion of transverse mesocolon under general anesthesia plus epidural block. Then the specimen was sent for histopathology, which showed purely differentiated carcinoma, which show Curie GIST stomach or neuroendocrine carcinoma. Then we have done a CD117, which came to negative. So we are in a dilemma. So we have done dog 1, which we showed also a negative. Then we have done chromogranin A and synaptophysin, which showed positive results, and Ka67 showed more than 20% mitocytes. Then the HPR report came, no lymphovascular invasion or perineural invasion. Margins were proximal and distal margins were free, and which is of large cell neuroendocrine carcinoma. So we came to a diagnosis, a neuroendocrine carcinoma arising from the stomach. Neuroendocrine tumors represent about 0.5% of all newly diagnosed malignancy. Neuroendocrine tumors are rare, slow-growing tumors that originate in the cells of diffuse endocrine system. They occur most frequently in tissues derived from embryonic gut. Neuroendocrine tumors develop most commonly in the gastrointestinal tract, commonly in appendix, then in small intestine. Neuroendocrine cells are cells that receive neuronal input which release messaging molecules to the blood. These hormones control many body functions. So they brings neural and endocrine integration, a process called neuroendocrine integration. Pituitary gland, parotid gland, parathyroid gland, and inner layer of adrenal gland are almost made up of neuroendocrine cells. Other neuroendocrine cells are found scattered throughout, mainly in gastrointestinal tract, respiratory tract, and pancreas. Incidence of gastric neuroendocrine tumors are less than 1%. These neuroendocrine cells found scattered throughout the cells, throughout these organs are referred to as the diffuse neuroendocrine system. Gastrointestinal tract has more neuroendocrine cells than any other part of the body. So it is a common site of neuroendocrine tumor, 64% of total cases. These are the cells from the neuroendocrine cells, that is from the parathyroid Merkel cells of skin, pancreatic endocrine cells, gastrointestinal tract cells, adrenal medulla or paraganglion, then miscellaneous from prostate, bladder, larynx, and other sites. It also comes from bronchopulmonary neuroendocrine cells, thymic cells, thyroid C cells, and adenophyses. From foregut, thymus, esophagus, lung, stomach, duodenum, and pancreas. From midgut, appendix, ileum, cecum, ascending colon, then hindgut, distal bowel, and rectum. WHO classification of 2019 tells like that neuroendocrine tumor grade 1 is well differentiated low grade, grade 2 well differentiated intermediate grade, and grade 3 well differentiated high grade. Neuroendocrine carcinoma small cell type, and third one is neuroendocrine carcinoma large cell type. Then mixed neuroendocrine, that is non neuroendocrine neoplasm. That is grade G1, G2, G3 are well differentiated. G1 is low grade, and G2 is intermediate, and G3 is high grade. We showed mitotic rate less than 2 in G1, intermediate, that is 2 to 220, and more than 20% in G3. That's Ka67 index is more than 20% in G3. In small cell type and large cell type, it is also more than 20%, which showed a high grade, that is poorly differentiated, and miscellaneous types showed well or poorly differentiated. That's grade and mitotic rate and Ka67 index may be variable. The neuroendocrine tumor is a which can be completely removing the entire tumor. It's the standard treatment for gastrointestinal tract neuroendocrine tumor. Most localized gastrointestinal tract neuroendocrine tumors are successfully treated with surgery alone. Usually remove some tissues surrounding the tumor called a margin in an effort to leave no traces of the cancer in the body. We can also use before surgery, we can use somatostatin analogs, that is octreotide or lanreotide, or chemotherapy or targeted therapy using everolimus, and then immunotherapy using interferon alpha 2b, and we can use peptide receptor radionuclide therapy using lutetium-8 177. For chemotherapy, we can use 5-fluorouracil, capecitabine, carboplatin, cisplatin, and dicarbazine, or etoposide, oxaliplatin, and streptozocin, and temozolomide.
Thank you, Dr. Ashwin. The topic is open for discussion.
You said only the transverse mesocolon was excised. Was the transverse colon excised?
No, portion.
In the appearance, you said that the transverse, it is adherent to the transverse colon, isn't it?
Yes, sir.
So
That part we have excised.
No, was the transverse colon excised?
Mesocolon.
Mesocolon. So you didn't have to sacrifice the middle colic vessels or anything?
No.
ഇല്ല അത് മറ്റേ മുഴത്തിൽ ലെയർ എടുക്കാമല്ലോ നമ്മൾ മെൻ്റൽ ബേഴ്സിലാണ്. What's the chance of metastasis? Neuroendocrine, they can metastasize. No, they are slow growing, but they can metastasize. At present, there are no metastases.
No metastasis. No, sir. No, sir.
Any carcinoid-like syndrome, carcinoid?
Sir. Pardon?
Carcinoid-like syndrome.
No, sir.
Thank you, Dr. Ashwin. The PG topic is concluded. Now, after the PG topic, it has been a practice to put the surgical club into lithotomy position. Now, for formal introduction from Dr. Nizamuddin.
Actually, today's topic is all onco topic, but still there is a lithotomy because the sponsors are like that. So for that video presentation, it's a rare thing, it's not so frequently done. We'll invite Dr. Nizamuddin. He is currently additional professor and head of the Department of Surgical Oncology in Malabar Cancer Center. He did his MBBS from Madras Medical College, MS from Calicut Medical College, and MCH from Tata. We had a short tenure working in MCC when I was working with sir. And sir is very keen in lab. He started lab when I was joining there. Now he has flourished like anything. So I thought I will have a new modality for rectal cancer treatment for a very selected patient. I will welcome Nisa.
Good evening. At the outset, let me thank the organizers of Calicut Surgical Club for inviting me to present this topic in front of my friends and my old teachers. I'm always happy to come back to Calicut. So today's topic is a relatively rare procedure that we do occasionally in our center. First of all, most of you will be aware of Malabar Cancer Center. You would have heard of it. Still, For those who are not very familiar with this institute, it's been recently renamed as Postgraduate Institute of Oncology Science and Research, PGI OSR. So it's an autonomous center under the government of Kerala. Currently we have around 210 beds. We are a fully NABH accredited hospital, and we hope to be around increase to 700 bed by 2027 by the time the new building construction is finished, which is going in a rapid pace. And we are one of the 3 apex cancer centers in Kerala, the other 2 being RCC and Kochi Cancer Center. And we around 7,000 to 8,000 new cancer cases every year and perform more than 2,100 major surgical procedures every year. So this is in a nutshell. And we have all the major facilities required for a cancer center, including PET scan, high-end linear accelerator, which linear accelerators, which are 3 numbers currently. And these are high-end machines for giving precision radiotherapy. And our center is regularly doing bone marrow transplantation. And in fact, this is the center with the maximum number of bone marrow transplantation in the government sector in Kerala. And we regularly do surgeries like HIPEC or heated intraperitoneal chemotherapy for advanced ovarian cancers, colorectal cancers, etc. We do regular minimally invasive surgeries and VATS surgeries. VATS is video assisted thoracoscopic surgeries. And we have fully accredited ethics committee, a research wing, HPCR or hospital based HBCR, hospital-based cancer registry, and PBCR, population-based cancer registry, which currently encompasses Kannur and Kasaragod district, and expanding to further 5 districts in Kerala. And we're expecting our Da Vinci robot by next month, and already the order is placed. And we have, it's quite a happening place actually. Currently we have DNB surgical oncology, and FNB in head and neck oncology, and FNB in gynae oncology starting this year. And we also run a fellowship program for in GI oncology. So with this, this is our department. We are a relatively young department. Those who sit in front are consultants, and the students are standing behind in 2 rows. And again, greetings from Malabar Cancer Center. So, scope of this talk, brief definition of early rectal cancer. What is early rectal cancer? Transanal excision and various options or procedures available to do this procedure. Indications, contraindications, the instrumentation that is being used, videos, 2 videos are there, and the complications and challenges that we occasionally come across, and some specific scenarios. So, early rectal cancer, it is an uncommon manifestation of a common disease. The definition of early rectal cancer is cancer limited to submucosa. It can be TIS, which is limited to mucosa, or intramucosal carcinoma, or T1, reaching up to submucosa. And there should not be any enlarged mesorectal lymph node, which is more than 6 millimeter. So that is N0. This is the definition of early rectal cancer. So we get around 3 to 5 cases of early rectal cancer in MCC out of the 120 to 140 rectal cancers that we treat every year. So this is less than around 4%. And yeah, this corresponds to the published literature, where in unscreened population, where there is no established screening protocol happening, the incidence of early rectal cancer is around 4%, which reflects our situation. Whereas in screened population, it increases to 25 to 30%. That means the moment we start screening in our population, the scope and the requirement and demand of this procedure is going to increase. So for those who do transanal excision or minimally invasive transanal minimally invasive surgery, just knowing whether it is T1 is not enough. You have to further subclassify T1 into SM1, SM2, SM3, which is simple to understand. SM1 means the first 1/3 of the submucosa is involved. SM2 the second one-third of the submucosa is invaded by the disease, and SM3 is last third of submucosa is invaded. To detect this SM status, we have to do endorectal ultrasound. MRI is important. MRI we have to do we have to add endorectal ultrasound to accurately identify the SM status of the cancer. Now, in SM1 disease, the risk of lymph node metastasis is less than 3%. So SM1 we can do transanal minimally invasive surgery, and in SM2 it is 3 to 10%. In selected cases, well differentiated small tumors, SM2 also you can choose for this procedure. Whereas in SM3, the risk of lymph node metastasis is up to 25%. So that is not an ideal candidate for this procedure. So what are the indications? Indications classically are lesions in the lower and mid rectum, which is accessible through this instrument and with minimal risk of peritoneal perforation, peritoneal entry. Polyps or adenomas, well differentiated or selected moderately differentiated cancers with no LVSI or PNI. LVSI is lymphovascular space invasion. PNI is perineural invasion. These two should be absent in the biopsy and should be involving less than 1/3 of the rectal wall. So as per the American Society of Colorectal Surgeons and ESMO is European Society of Medical Oncology, the recommendation is T1, N0, SM1 or SM2. And in the US multi-society task force has slightly varying definition or indication, that is instead of SM1 and SM2 they put it as less than 1 millimeter submucosal invasion, which approximately same. So these are the some of the cases that we have operated in Malabar Cancer Center. So all this you can see that these are small lesions with less than 1/3 of the wall involved. What are the contraindications? Absolute contraindication is T1, SM3 or higher. High grade or poorly differentiated cancers you should not do, and those with LVSA or PNI and with the positive lymph nodes. Some relative contraindications are more than 3 centimeter lesions and those involving more than 1/3 of the bowel wall. I said relative because as the expertise for the procedure increase, you can you will be able to extend the indication. Sometimes you may be able to do a procedure with 4 centimeter or involving slightly more than 1/3 of the bowel wall. So it's a relative contraindication only. There are some unclear indications. So these are not standard indications, but these are some of the evolving indications. As you are aware that there is an increasing quest for doing non-operative management in rectal cancer. There are some options coming up. So some patients, some situations where we get complete clinical response after chemo radiation, even in locally advanced rectal cancer, some patients choose to get not operated, or some clinicians to choose to observe. There are some evidence from the literature to cite that. So there is a move on surgical management of rectal cancer. So people have sought the option of doing this procedure instead of a major rectal cancer surgery in patients with the T1 high risk or T2 disease after neoadjuvant chemoradiation, organ preservation option, or adjuvant CTRT after excision of this T2 disease. These are indications under evaluation, under a trial now. And those with a near complete or partial response, there's a minimal residual disease. That is another area where this procedure is being employed as a trial protocol. So what investigations are required before this procedure? MRI pelvis is mandatory, and CT abdomen and thorax we routinely do for all rectal cancers, and these cases also we do. If we ask strictly whether CT thorax is required, maybe not, but these are very small number of cases among a sea of other rectal cancers. So these patients also get similar investigations are the other rectal cancers, and after all the stage is sum total of all these investigations. So after all these investigations, when the patient come to us, we decide the stage. So these are routine standard investigations for these cases in our institute, and all patients will go for endorectal ultrasound to decide the SM status. Digital rectal examination by the operating surgeon is mandatory. Many times it is the DRE which detect early disease. The radiologist would have found some fibrosis or signal changes in the extending to muscularis propria, or even mesorectal fat, and they may report as T2 or T3 in the initial report. And when we do the clinical examination, when we detect a polypoid lesion, small polyp, we look carefully at the MRI and we'll go and discuss with the radiologist, which after discussion with the radiologist, sometimes we arrive at a conclusion that MRI has actually overstaged. And then we send these patients for endorectal ultrasound, and sometimes that helps to select these patients for these procedures, or avoid a otherwise extensive procedure which would have been done on that patient based on that earlier report. So that is very important. And colonoscopy or rigid sigmoidoscopy is important. We have to do it. We cannot depend on the report of a medical gastroenterologist to know the exact location, size, and the stalk width of the tumor in order to avoid intraoperative surprises. We have to do it. And MDT discussion is mandatory before you do such procedures. MDT is a multidisciplinary tumor board, where other subspecialties of oncology are available. So what are the types or options of transanal excision? There are different options. Essentially, the procedure is same. You have to remove the disease with the mucosa, submucosa, and muscularis propria. So full thickness of the rectal wall you have to remove, along with adequate margin around. That is the procedure. But you have multiple options for this. Conventional transanal excision you can do. Yes, for those lesions which are situated close to the anal verge, maybe till 5-6 centimeter, you can do a conventional transanal excision using a Lone Star retractor. This is the Lone Star retractor. You can get a good exposure with the retractor. And conventionally, with this technique, you can use another one or two metallic retractors, and you can do that. But for those lesions which are beyond 4 centimeter or 5 centimeter, it becomes difficult. So in such situations, you can do something called TAMIS. You can do TEMS, or transanal endoscopic microsurgery, or transanal endoscopic operation, or TEO. So I said procedure is the same. What you do is the same, but only the instrumentation that you use is different. TAMIS is when we use a disposable platform with a jelly. I'll come to that. That is called TAMIS. And TEMS was the first metallic, rigid, permanent platform designed for this procedure by Dr. Gerard Bues, who was a German surgeon. And currently that is not being marketed. Now what we have is TEO, transanal endoscopic operation, which is a trade name from STOS. So they produce this instrument, and this is the instrument currently we have in our center. So we'll see these platforms. So these are the different access platforms. On the left side, you have the gel point path, which is produced by Axis Surgicals. It's a disposable instrument. So it has 3 parts. Tube. This is the rectal tube, and this is the jelly platform through which you can insert the separately provided ports. So when you assemble, this is connected to this tube, and this tube goes into the rectum, and onto this platform you insert these ports according to you can custom the ports placements according to the location of the tumor. That is the advantage of these disposable platforms, whereas in rigid platforms you cannot do that. And this is the rigid platform that we have in our center. It's a reusable autoclavable instrument. This is a camera, this is the obturator, and this is the rectoscope. This is a TEO. So what are the differences between disposable platform and platforms? I said in disposable platform you can customize the port site. You can insert the port wherever is required, depending on the location of the tumor, depending on the clock position of the tumor. Whereas in the rigid platform, these port positions are fixed. You cannot move it. So you have to change the position of the patient to suit the location to operate comfortably. Disposable instruments can be used in lithotomy position most locations of the tumor, but they have a short fixed tube length. Whereas in this instrument you have multiple tube lengths available. Intraoperative positioning is difficult in a disposable platform because this platform is sutured to the perineal skin. So you cannot keep cutting the sutures and keep on changing it. Whereas in the permanent platform, you can keep changing the position of the instrument to suit the location of the tumor because it is attached to the table. You can change it. One problem with the disposable platform is high consumable cost. Before getting the permanent metallic platform, we used to use disposable platform. That time, before 2018, it used to cost around 55,000 per platform, and we can use to a maximum of 2 times. Beyond which, if we use it, we cannot go forward to start leaking air. So we cannot use this. And but this platform is useful for a procedure called TATME. TATME is a transanal TME. I'm not going into that. Whereas these permanent platforms are costlier, but the recurring cost is less. So these are different resectoscopes with the different lengths. So depending on the location of the tumor, distance from the anal verge, you can use instruments with 20 centimeter, 15 centimeter, or 8 centimeter. And the corresponding obturators, camera, diaphragms, and these are the cameras with the different length, scopes with the different length. Usually we give around 1 centimeter margin around the tumor, and we go till the mesorectal plane. We see the mesorectal fat and remove it. So I said T2 in some of the scenarios I would like to tell you. I think we will come back to it after the video. There are 2 videos. One is an uneventful video. In second video, I end up, I had to, okay. This is the instrument which I already showed in the PPT. This is the resectoscope. This is the face of the diaphragm. These are the working ports. These are 2 working ports. This is for the camera, and this is for clip applicators. To introduce a clip applicator, 10 mm clip applicator, and these are the ports for connecting the gas. Okay, these are the specific curved instruments for doing this procedure: curved needle holder, curved cautery with suction, Alice forceps, scissors, and this is the table attachment. Using this system, this is how the patient is. This patient is placed in the lithotomy position with the resectoscope placed inside, and this is the camera attached. Camera into the camera port, gas attachment, and you have one more port for intraoperative flushing if required. So this system is attached to the table, using the table attachment which is provided along with the system. So it remains stable. So once it is attached, it will not move. So it is easy to work on that. So this is a tumor. Bleeding was a presentation of the tumor. So, yeah, I skipped a slide there regarding the patient data. One slide was there. This is a female patient who presented the bleeding. And this lesion is situated around 7 centimeters from anal verge on the posterior surface, the posterior surface of the rectum. And MRI and endorectal ultrasound showed T1 disease. So we decided to go ahead with this procedure after discussing the case in the multi-specialty board. Patient is placed in the lithotomy under general anesthesia. Sometimes I put dots across the lesion at 1 centimeter length to to stick to the correct margins. Sometimes, in this case I have not done that. In the second case I will show you that. So once the mucosa, submucosa and muscle are cut, we see the mesorectal fat. So basically see the mesorectal fat and remove the tumor. This cautery has suction in the same lumen. So while operating the cautery, you can activate the suction also. So that is why this air is getting sucked and the rectal wall is moving during the procedure. Curved instruments make the procedure, it's very handy. Though in the magnified view you are seeing a big lumen here, but actually it's a very small lumen. The rectal wall, it's nothing compared to laparoscopy. The area where you move your instrument is very small tube of rectum. So we have a very small room to maneuver the instruments. That is why we need curved instruments. It's very difficult to do this procedure using our conventional laparoscopic instruments. So in this case, usually these lesions will have a pedicle. So this pedicle, the bleeding did not get controlled with the cautery. Then I had to use a ligashore and control it. So after resection, so the moment you cut the muscularis propria, the defect will expand. And so this is the size of the defect for such a lesion. That is why for lesions which are involving more than 1/3 of the rectal wall, it's a relative contraindication. Because when you do that, the defect becomes too big. So when you close, sometimes it can result in narrowing and subsequent strictures. So we have to close this defect, because otherwise this will come in contact with the fecal matter and will get infected, and you can get perirectal abscesses. So we have to close this rectal wall watertight. It's possible to place nodes inside this rectal lumen. So what I do is, after pulling the thread, I place clips. We have to close the defect transversely, but in this case it's a huge defect. I started transversely, but somehow it became oblique. But we have to make sure that the rectal lumen is not getting obliterated. So after pulling the thread tight, it's very difficult to place knot. So we place a clip overlapping onto the rectal mucosa so that it remains there. So after that, we will pack the lumen with the paraffin gauze, which is kept for 24 hours to give some pressure to avoid hematoma formation in the wall. So this specimen is examined for margins and sent for histopathology. One more video I would like to show you. In this case, this is a male patient who was 75-year-old, and not so good general condition to undergo a major surgical procedure. The radiologist reported it as a T2 disease. It's an anteriorly placed disease. The patient is placed in the prone position. The radiologist reported as a T2 disease, but clinically we thought it's a small disease. So we went and discussed with the radiologist. After endorectal ultrasound, it was reported as T1. So we gave the option of doing this transanal procedure to the patient, because otherwise the patient would not be fit for a major procedure. So this patient is in the prone position, and this area approximately corresponds to the area where we get the proximal prostate and seminal vesicles. So in this case, there is a risk of peritoneal entry, because if we go forward too much, there is a risk of peritoneal entry. So I put cautery marks around the lesion for easy identification of margins. Similarly, we have to cut across the entire rectal wall and reach the perirectal fat. Smoke is a problem because it's a very small lumen, and it's very easily it gets filled with the smoke. So fortunately, we have this suction attached to this cautery itself. So at the same time, we can suck the smoke out. But what happens when we suck the smoke out? Suddenly, the lumen will collapse. So sometimes interrupting the procedure that we do. So we're coming to the completion of the resection part. So always we have to go underneath and before detaching the further attachments, further end of the side of the mucosa, we have to finish the deep dissection. This procedure is similar. It would have been otherwise uneventful procedure, but something happened intraoperatively. Coming to the last mucosal and attachments. So this specimen is coming along with the mucosa, submucosa, and the muscularis propria. That is full rectal wall. As you know, there is no serosa for the rectum. So again, there was a bleeding from the pedicle, which I controlled with the ligashure. Specimen was excised, then the procedure would have been otherwise uneventful, but then I noticed this problem. This is a huge problem that I noticed. So just beyond this, there is a perforation, huge perforation, which would have been small in the beginning, but expanded with the pressure of the carbon dioxide. So there's a big dissection. Then I examined the abdomen. Then I found that there is no pneumoperitoneum. So the air has not gone to the abdomen. So then I realized it's an extraperitoneal perforation. And decided to close with the suture. So after closing that perforation, I closed this resection defect also. So finally, rectal wall is repaired and there is no defect. So coming to the last few slides of the PPT, yeah, there are some evidence whether we can do. Okay. This is regarding the sometimes when we do TAMIS, you can get a histopathological surprise. That is T2 in the histopathology. So your clinical examination, your radiology report, or even endorectal ultrasound sometimes can go wrong. So we had one equation where we had such a situation. In the final histopathology, radiologist says there is a focal invasion of the muscularis propria. So then we had to search the literature. Then what to do? When you do some rare procedures, then you are responsible for that also to lead to a normal pathway. So we had to we search the literature. The standard recommendation is to do TME. If the patient is fit to undergo a major procedure, do a TME. And if the patient is not willing, adjuvant CTRT and surveillance is an option. And in the literature, there is a higher chance of local recurrence reported as high as 14% with such an approach, whereas if you convert to TME, it is 7%. So you have to carefully discuss with the patient, because sometimes when you do major procedure after this, the complication rates can be higher also. So there is in the beginning I mentioned there is a novel approach to, in T2 diseases, whether you can do NACTRT followed by this transanal procedure. Yes, there are evidence available in the literature. One study shows 88% 3-year disease-free survival with an approach. But that's not been accepted as mainstream treatment, so still investigational. So these are various trials which examined doing this procedure after NACTRT in lesions up to T3. So consistently what they found is, one finding is that if the residual disease is T1, that is initially it would have been T2 or T3, and after chemo radiation, if the residual disease in the histopathology is T1, the control rate is good. If it is more than T1 or T2 or high, and if you have a margin positivity in the transanal excision specimen, and if the disease has LVSI or PNA, or if it is poorly differentiated, there is a higher local recurrence and it's not acceptable. The local recurrence rate is as high as 36% and it's as high as 24% and 60% if we do in such cases. So it's not acceptable. So in control excision as a salt patients with more than or equal to T2 is investigational. So this is the description of the patient in the video. And finally, the histopathology reported as well differentiated adenocarcinoma, and it was T1, and the patient received, the case was again discussed in the multidisciplinary tumor board and decided to observe. And what are some complications which come across procedure? One is bleeding, next is abscess formation, and accidental peritoneal entry. So usually we do in after a very good bowel preparation. It is very important. We have to do this procedure only after very good bowel preparation. And in a well-prepared bowel, if there is no contamination, accidental peritoneal entry can be sutured and you can get away if there is no contamination to the peritoneum. So if you have to convert it to TME, you find it difficult sometimes because fibrosis develop in that area. Accurate staging is mandatory. Technically, it's more challenging than usual laparoscopic procedures, where you have no option to convert to open. You cannot convert to open in this case. So if you start with the procedure, you have to finish it. So it is always better to get some experience from the laparoscopy before venturing into this procedure. So measures you have to, you cannot go you cannot choose disease which are situated too far away from the anus to avoid peritoneal entry. And shrinkage of margins is a problem. So once you excise the lesion, you have to mark the margins using pins as shown in the picture. Otherwise, once it shrinks, the pathologist will report it as margin positivity. You would have taken 1 centimeter margin around, but when the report comes, there will be a problem. So far in MCC from 2018, we have done 16 cases. 10 females, age ranging from 34 to 75 years. 14 of those cases were adenocarcinoma T1 or T in situ, and 2 were neuroendocrine tumors. We had some morbidity. One patient had rectal abscess. One patient had bleeding, which occurred 2 days later, which required blood transfusions. And one patient had a pathological surprise, that is PT2 in the histopathology. Our follow-up is duration. The duration of follow-up is very low. So it's too premature to talk about any survival or local recurrence at this stage. Maybe after 2 or 3 years, at least 5 years follow-up is recommended to talk about survival or local recurrence in such cases. One of the 16 patients in our series had a liver metastasis later, after 8 months, and 2 patients lost follow-up. Remaining 13 patients are still under our follow-up, and they are disease-free. Thank you.
Topic is open for discussion.
Thank you. A wonderful presentation.
Thank you, sir.
Good idea. I've just a couple of questions. Suppose it is on the anterior side.
Yes.
So the lesion is on the anterior side. Male patient,
Yes.
closer to the prostate or the denenvillus. How do you proceed then?
So the second patient I showed in the video is had a tumor anteriorly. So we have to look at the MRI and see whether if the lesion is beyond peritoneal reflection, or if you are likely to go beyond peritoneal reflection for your margins. That's not very ideal case. So it's difficult.
Now, what suture material you use?
I used Vicryl for closures.
Can you use the barbed Vicryl so that
We can use that. We can use that.
you can use
Yes.
it? So that you can you avoid that staple, the final
Yes.
staple that you put in the?
Yes, we can do that. Yeah.
Is an absorbable staple or?
It is absorbable sutures. It is a.
No, the
oh, you
staple.
sir, you mean the clip? It's not
The clip,
absorbable.
yeah.
No, it's not absorbable. This is same clip,
yeah.
that polymer clip that we use in laparoscopy. Yeah.
Okay, fine. ഗുണമൊക്കെ
I think it will fall off, sir, because Vicryl will go, so the clip has to fall.
Right. Because the other thing was, my doubt was whether after resection, if it is T2 or the SM3, what next? You already answered that. Thank you very much.
Nishamuddin, nice presentation. Happy that you are our postgraduate student of Calicut Medical College. You're progressing well. The question is, we have had issues of rectal cancers
Yes.
when the patient is not willing for surgery. Because many of time when there is lower third rectal cancer, and if we suggest APR,
Okay.
most of them may not be willing. So, in your opinion, is the local resection after neoadjuvant chemo-RT for the residual disease, or intersphincteric resection, which is done by most of the surgeons for preserving sphincter, which is better?
Okay, sir, there are various approaches to this situation. We sometimes get such patients. So if for locally advanced, first of all, for a locally advanced rectal cancer, doing intersphincteric resection is not a good idea, first of all. So it is better not to plan that way. On the other hand, what we did is, we offered this patient total neoadjuvant therapy. That is, we gave a short course radiation for 5 days, and after that we gave total neoadjuvant therapy. All 6 cycles of chemotherapy were given. So this with such approach, the pathological complete response, the total complete clinical response around 50-60%. So a significant number of them have a pathological complete response also. So that is one option. So even if they don't get complete pathological response, in such patients, what we are looking at is a long-term remission. So next 2-3 years, usually this patient is safe. So they will not recur.
We have done 2 patients of excision rectal cancer. Most of them were not willing for APR.
Okay.
The second specimen, the report came as muscle invasion was there.
Okay.
So, subjected for the patient for
We
radiation.
can do that, yeah.
Patient is completed 9 years.
Yeah. We can do that, sir.
Recently died of upper GI bleed.
Okay, we can do that. This option is coming up actually. Local excision for this patient. I mentioned they touched upon my talk. This option is coming up, but they reported high morbidity with such procedures. Local excision after chemo radiation in advanced cases and high recurrence rate. So,
have you ever given a submucous injection of saline or something like that and excised?
so that is what the endoscopists do. Endoscopic submucosal dissection, they inject saline, but we don't need that, sir.
Then what type of individual usually will
and it's for injecting. We cannot inject saline through this platform. There's no options for using endoscopy. Prior to this procedure we can do, but it's not required. We have cautery and we can control the bleeding. So
another is, what type of individual usually you will do screening actually? Symptomatic patient or asymptomatic?
so at present we don't have an organized screening in ours anywhere in India, in my knowledge. What we have is opportunistic screening only. Occasionally random patients go for screening. So there is no organized screening in our nation now.
I think endoscopic surgeons do the receptive muscularis also. They are staying in the submucous.
Yeah, they don't.
Space only.
Yes, they don't do that.
Is that the oncological clearance adequate?
Whereas are in endoscopic research, they do that for non-malignant cases, adenomas. Yes. So that particular patient had
Or it
a.
was only the S1, the submucosal only. That is the
So that
T1,
patient.
T1 only.
That was T1 only. Post-operative
Not
histopathology.
not the one after the radiotherapy, chemoradiotherapy.
This patient,
The one that
post-operative.
you had the recurrence.
Yes. So,
That patient had chemoradiation.
sir, can I understand that you are asking whether what was the histopathology of this patient after this procedure? Is it right, sir?
That the indication for the surgery, that is the excision,
Yeah.
that you said it is the T1.
Yes.
And that you are trying to do the after chemoradiation also you are doing, isn't it?
No, we have not done that.
Not doing.
So all our cases are early rectal cancers,
Not after chemoradiation.
not after chemoradiation.
I think it can be closed in short of time.
Thank you.
Thank you, Nisam. There will be a small announcement of quiz prize. Actually, we'll announce the prize. It's a sort of small cash prize, but the thing is that we have arranged for the first and second team. Cash will be there. You will be having a luxury of having a laparoscopic or cadaveric or whatever you want, some sort of training for 2 days with the two multinational companies. I cannot announce the name because if the NMC norms go against that, we'll have to cancel that. After passing your MS, you will be whatever field, be it hernia, coli or anything, you can go for 2-day training entirely sponsored by that companies. That will be the price for first and second. First will have the privilege to choose the better one, and second will be having this one. So you can inform us. Apart from this, we will be having a cash prize. So we'll announce the results. The third prize is for MMC, Dr. Abhishek and Prasad. They will receive a cash prize of 1,000 rupees only. They don't have any luxury of. I'm trying for them also. If you also get, we will sponsor you people also. So can you please come? I request Sarvottaman sir to give a prize for the Prasad and Abhishek. Second is Jerry and Dakshaya from Calicut Medical College. They will get a cash prize of 2,000 rupees plus their choice of training, 2-day training entirely sponsored by the company. I request Rajan sir to Yes, sir. Joji sir to hand over the prize to the second witness. And third is, first is by Dr. Reina and Dr. Mohammed Sanif from MIMS Calicut. I request PT Mohandas sir to hand over the prize to them. Can you please, Reina and Shani? There's a Dr. Sona needs to be felicitated. She was the quiz master. She did an excellent work. She was also having some moment, she is not unable to. And we will move to the next topic.
Next topic is by Dr. Shyam Vikram, HOD Surgical Oncology, MVR Cancer Center. He is not new to this floor as a speaker, and therefore he doesn't require a formal introduction, I think. So we will move on to the topic, post-appendicectomy surprise malignancies.
Respected teachers, senior colleagues, and my dear friends, and the outset I thank Calicut Surgical Club for giving me a chance. Actually, appendix is one subsite in abdomen, unlike other colorectal or GA, other GA malignancies, where pathology is very important. And in addition to the stage of the disease, in other subsites, the stage of the disease decides the management. But in coming to the appendix, the pathology also plays a major role where we decide the management for the tumors. And we use, unlike in other subsites, we use many terminologies only for the appendicular malignancies. And most of the tumors are, of course, post-operatively we get the diagnosis after the pathological surprise. And because in my presentation, few slides, majority of the slides describes about the pathology, because we should have an idea about the pathology before you come into the management. As we all know, the appendectomy is one of the most common performed emergency abdominal surgeries, with 3% of the specimen shows pathological surprise as malignancy or neoplasms. It can be benign as well. Then the primary appendiceal neoplasms entity is less than 1%. And coming to the classification, it's the serrated polyps. It can be benign, like serrated polyps, and it can be low-grade neoplasms like LAMN, HAMN, mucosal adenocarcinoma. So broadly, it can be in the epithelial and non-epithelial, or carcinoid or non-carcinoid type of tumors. And in this, we can have the high-grade tumors, low-grade tumors, and benign tumors as well. And this is the peritoneal surface oncology group classification. It classifies into mucinous epithelial neoplasms, into serrated polyps, and low-grade mucinous neoplasms are called as LAMN, and high-grade called HAMN, and mucinous adenocarcinoma are the signet ring cells. And then comes the non-mucinous tumors like adenoma and adenocarcinoma. Then the neuroendocrine, like one more aggressive variant called the goblet cell carcinoid, and then other mesenchymal tumors. So this is the commonly accepted the classification of malignancies in or tumors in the appendix. So coming to the 8th edition of the AJCC, we just want to concentrate on one thing, that is the TIS, that is carcinoma in situ. We know that it's not tumors which not infiltrating the basement membrane, but here there is a difference for the TIS of the tumor, carcinoma of the appendix, and TIS of the LAMN or low-grade mucinous neoplasm. There's carcinoma, the carcinoma in situ or TIS is described as the tumor invasion into the lamina propria or extension, but not through the muscularis mucosa. That is the for the any tumors, any TIS of TIS for any tumors. That is the definition given. But when it comes to the LAMN, that is low-grade mucinous appendiceal neoplasm, it gives the mucinous neoplasm confined to the muscularis propria. And one thing is that after TIS for LAMN, that is low-grade mucinous neoplasm, we have T3 and T4. We don't have T1 and T2 for the LAMN. Why? Because in any other tumors, if we take T2, that is the lamina propria. Lamina propria involvement. But when it comes into lamina propria involvement in the LAMN, that becomes the TIS. So after TIS for AJCC classification is T3 and T4 for LAMN. That should be noted. And coming to the nodal status and M1 and for metastatic, again it is M1A. That is intraperitoneal acellular mucin. That is the peritoneum will be filled with mucin without any epithelial cells. That is called acellular mucin. That is M1, classified as M1A. And if it is cellular mucin, that is contains tumor cells, that is becomes the M1B, and M1C is metastasis to the other sites other than the peritoneum. So coming to the mucinous appendiceal neoplasms or MANs, it's a unique tumors with more than 50% of the tumor volume composed of extracellular mucin. And as all of us knows, it's common that the presentation, either it can be an unruptured mucin-filled appendix, we often called as mucocele of the appendix, which is diagnosed very much in ultrasound or CT scan, or it can be at a peritoneal metastasis after rupture. It can present as a peritoneal carcinomatosis or even the jelly belly, that is we call that is the pseudomyxoma peritoneum. So these are the commonest presentations what we see in appendicular neoplasm, mucinous appendicular neoplasms. These are the things what we are discussing. The low-grade MANs or the LAMN is the low-grade cytology. What is the most important factor, most important thing, pathological feature what we should, as a surgeons, we should note is that it doesn't infiltrate or invade any of the organs. So that is the pathognomonic feature by which it is, and the cellularity shows a low-grade cytology, low-grade cytological alteration, that is called LAMN. And if the same features with a high-grade cytological features, that becomes a HAM. That is the only difference between HAM and LAMN, or high-grade mucinous neoplasms and low-grade mucinous neoplasm. But when it comes to the mucinous appendicular adenocarcinomas, there will be infiltration and invasion of the adjacent structures or organs. And again, the same thing what we had is what I was discussing. It's after TIS, we have only T3 because the lamina propria involvement in LAMN is still considered as a TIS because of its character and because of its behavior. And pathological features, and I just want to say the two pathognomonic pathological features of the LAMN is, one is the loss of or absence of lamina propria and muscularis mucosa and fibrosis of the submucosa. These two are the features by which a pathologist call it as a LAMN or low-grade mucinous neoplasm. And the high-grade, the same features with the high-grade epithelial features or cellular features. And mucinous adenocarcinoma, or as we know, it is an infiltrating tumor. And again, it's a repetition. In T4, again T4 is the infiltration of the organs, peritoneal invasion, visceral peritoneal invasion. Risk of peritoneal recurrence is 4 to 17% in acellular mucin. So that also plays a major role in the recurrence in the tumors. So if it is an acellular mucin, the recurrence rate is 4 to 17%, and if it comes to the cellular mucin, it becomes 8 to 75%. And HAMN, which already we known. Then comes to the pseudomyxoma peritoneae. Again, we call the jelly belly, that is the abdomen filled with jelly-like material or mucinous material. It's a rare peritoneal malignancy and most commonly originating from perforated epithelial tumors of the appendix. That is the most common site of pseudomyxoma peritoneae. And PMB is one thing to be noted is that the PMB is not a histological diagnosis, it's a clinical diagnosis by which we call the myxoma peritoneae. Also, other organs like colon, ovary, all can be the primary site. Appendicular neoplasms, mucinous neoplasms become the most common cause of reason for the pseudomyxoma peritoneae. And pathogenesis of PMB almost invariably starts with, as we know, it's a perforated appendix is the cause of the pseudomyxoma almost always. And perforation spills the tumor into the peritoneum, then causes the mucin. It can be either a cellular mucin or a cellular mucin. And the site of the most common, and it's a predictable, the spread of the mucin in the intra-abdominal is a predictable way by which we know the peritoneal fluid moves from the pelvis to the cordocranial way. So the most common sites which is affected as the right paracolic gutter, right and left subdiaphragmatic spaces, the omentum and the pelvic peritoneum. And the small bowel mesentery is relatively spared, but it can also be affected because of its movements, continuous movements of the small bowel. It's relatively been spared in the early stages of the pseudomyxoma, but towards the later stages, the whole of the abdominal organs will be filled or covered with the mucin. Then the histological classification of the PMB, it can be again into acellular mucin, low-grade mucinous carcinoma peritoneae, high-grade and high-grade mucinous carcinoma peritoneae with the signet ring cells. So this is the how it, even though it is the mucinous filled abdomen, it can be graded according to the histological features of the cells which is present in the mucin. And coming to the perforated appendix, when the staging can be particularly difficult because most of the time it can be a single site of perforation or it can be the whole of this wall can be sloughed off. And again the diagnosis, the T stage and the diagnosis depends upon the remaining lamina propria or remaining the muscularis propria by which the diagnosis is been derived from the T stage especially. And then coming to the appendicular adenocarcinoma, the mucinous adenocarcinoma, invades the glands. As we already know, its invasion and infiltration is the pathognomonic feature for the mucinous adenocarcinomas of the appendix. And it resembles the colorectal counterparts. And the treatment almost always goes, if it is a limited disease, it is almost always goes like that of a colorectal carcinoma. And gobletal carcinoid is another aggressive variant which comes between the carcinoid and the adenocarcinoma, which has a more predilection for distant metastasis and lymph nodular metastasis. And this is the peritoneal PCA which decides one of the factors by which the peritoneal carcinomatous index, which is being calculated before the surgical intervention. The most common tool we use is the MRI to calculate the PCA, and it depends upon the PCA we decide upon the treatment in mucinous carcinomas of the mucinous tumors of the appendix. We divide the abdomen into 9 compartments, and then the small bowel is been the upper jejunum, lower mid jejunum, upper ileum and lower ileum, and these 4 sites of this small intestine has also been taken into consideration to calculate the PCA. And then the completeness CC is the completeness of the cytoreduction, how much tumors have been debulked from the tumor. If we are not left behind any tumor, that we call it as a CC0. And if it is a CC1, that is tumors of less than 0.25 centimeters have been left behind at a given site. And at CC2 is 0.25 to 2.5, and CC3 is more than 2.5 centimeters. So this is mainly for the cytoreductive surgeries and HIPEC we calculate before, and after the procedure we document the CC status or completeness of the cytoreductive status. Coming to the management, See, controversies regarding the surgical management of a localized MAN is often diagnosed intra or post-op because it's often a pathological surprise that we have dealt with a mucinous or any appendicular neoplasm. We would have operated for a acute appendicitis, but the majority of the time it is a pathological surprise. And dilated and enlarged appendix is encountered, it must be removed carefully because that always we get a diagnosis by the ultrasound or a CT scan which gives a dilated mucin filled appendix. So we can get away with a surgical removal of the appendix with carefully make sure that there is no spillage of the mucin. We can get away with the appendicectomy alone. And laparoscopic appendicectomy is indicated in a mucosal of the appendix provided you take it out clearly without any mucin spillage in the back. And right hemicolectomy actually it's not a standard procedure for the all neoplasms of the appendix, and it doesn't give much advantage for the patient. So I'll come to it. So many of the neoplasms, a simple appendicectomy or other related procedures will suffice the management. And of course, some of the tumors like mucinous adenocarcinomas and the goblet cell carcinomas, lymph nodular metastasis is an important prognostic factor. Low-grade tumors rarely have lymph node disease. So LAMN doesn't usually spread to the lymph nodes. But when it comes to the grade 2 and grade 3 tumors, it has a more predilection for lymph nodular spread of around 17% and 72% respectively. That gives us an indication that lymph nodular dissection should be done. In oncology, majority of the organ resection depends upon how much lymph node dissection has to be done. So in such cases, we have to go for a right hemicolectomy. And even evidences says that a low-grade and pathological surprise of low-grade tumor with a margin negative tumors, even with a very, I'll come to it, localized mucin in the peritoneum, we can have a surveillance for the patient and go in when it recurs. So low-grade tumors can keep the patient under surveillance in LAMN patients. And right hemicolectomy performed for grade 2 and grade 3 MANs and staging for oncological purposes, as I said. And whenever we do a laparoscopy or an open procedure, and complete examination of the abdominal cavity, peritoneal cavity should be done, especially the diaphragmatic areas, the root of the mesentery, the paracolic gutters, pelvic peritoneum. All these have to be examined to make sure that there is no mucin deposit present in the abdomen, because that makes a difference in the management. Coming to the unexpected appendiceal tumor, mucinous cystadenoma and serrated adenomas, that we have said that the benign tumors of the appendix. In case of a serrated adenoma or a hyperplastic polyp, and a simple appendicectomy with a clear margin will complete the treatment for the patient. And coming to the carcinoid tumors, some of the factors by which we decide what extent we do the surgery is, one is the size of the tumor. A less than 1 centimeter tumor with an appendicectomy with a clear margin and a simple appendicectomy will suffice the treatment. But when it comes to 1 to 2 centimeter tumor with a positive or unclear margins, with a mesoappendial invasion of more than 3 millimeters and presence of lymphovascular invasion, and Ki-67 3 to 20%. In the first it is less than 2, and this is 3 to 20%, a right hemicolectomy is warranted. And again for a more than 2 or more than 2 centimeter tumor, with a Ki-67 more than 20%, again a right hemicolectomy is warranted for a carcinoid tumor. Coming to, as I said, the goblet cell tumor, still more aggressive tumor when compared to the normal NETs. It's more aggressive than NETs and more predilection to have peritoneal spread and lymph nodular metastasis. So in such tumors, radical surgery is more aggressive radical surgery has been indicated in such tumors. And again, for goblet cell tumors also, we have some of the features by which we categorize the tumor. This is the Tang classification is there, Tang A, B, and C. So Tang A lesion, that is the classical cell tumor, and P, T1 or T2 tumor of less than 2 centimeters, clear margins after appendicectomy, a mesoappendiceal invasion of less than 3 millimeter, no LVI or PNI, and Ki67 of less than 2%. If after an appendicectomy, if all these features have been satisfactorily achieved, then a simple appendicectomy will do. But if in any change in any one of these features, we'll have to go for a right hemicolectomy in case of a goblet cell tumor. And a non-perforated goblet cell tumor without peritoneal spread after the staging and no CRS or hypoc is warranted. And a perforated tumors, of course, we have to go for cytoreductive surgery and a hypoc. Coming to the LAMN or low-grade mucinous appendiceal neoplasms, if it is perforated, if it is not perforated, we can clearly follow up, keep the patient under surveillance. If it is perforated and just see for there is any peritoneal disease. If there is no peritoneal disease, we have options of surveillance as well as prophylactic hypoc, that is cytoreductive surgery with hypoc, but there is no radical right hemicolectomy is warranted. Limited peritonectomy and hypoc can be considered. But if there is a peritoneal disease, again we have already seen how to calculate the PCI. If it is less than 3 PCI, we have an option of surveillance. And we have an option of either CRS plus hypoc, or if it is less than 3, PCI 3, that is a very limited mucin, very, very close to the appendix, limited to the mesoappendix or so, we can have surveillance or hypoc, CRS plus hypoc. But if the PCA is more than 3, then definitely we'll have to better to consider CRS plus hypoc for a LAMN. For HAMN, for any practical purpose, HAMN or high-grade mucinous neoplasms are considered and managed according to the protocol for the mucinous tumors, adenocarcinomas of the appendix. So because the chance of recurrence is high in HAMN, so treatment also goes according to the adenocarcinomas. So in where which are all conditions we consider only the appendicectomy. One, the condition is non-perforated after appendicectomy, that is the tumor is TIS or T3, there is no nodes, and post-operatively after the appendicectomy, after 2 to 3 weeks, we will have to take a CT scan of the abdomen, contrast CT of the abdomen, and it doesn't show any disease anywhere else in the abdomen. No right hemicolectomy should be considered. And the second situation is a perforated LAMN after appendicectomy. That is a T4A or T4B condition. It's a cellular mucin or acellular mucin in the peritoneum, but there is no postoperative radiology, postoperative evidence of any residual disease in the abdomen, and right hemicolectomy is not indicated in such condition. In these conditions, we can get away with a appendicectomy alone. And a LAMN after appendicectomy with any T, right hemicolectomy should never be considered. So in general, if we see an LAMN, low-grade mucinous tumors with a very limited disease, if at all it is there, or a non-perforated tumors, just an appendicectomy will complete the treatment. In which all conditions we should go for a right hemicolectomy? One is the perforated HAMN. As we already know that HAMN is a high-grade tumor with a high chance of recurrence. So we'll have to go for, especially in a perforated tumors, we'll have to go for a right hemicolectomy. Then mucinous adenocarcinomas of the appendix, any grade, let it be grade 1, 2 or 3. And mucinous adenocarcinomas with signet ring cell component, we'll have to consider a right hemicolectomy, and of course the goblet cell carcinoids. And wherever we consider the CRS plus hypoc, that is a cytoreductive surgery. It's a perforated LAMN after appendicectomy with T4A with a PCA more than 3, we can consider a CRS plus hypoc for these patients. And for LAMN after appendicectomy, cellular or acellular mucin with no residual disease, any T, adjuvant CRS could be considered. That is, again, it depends upon the PCA index of the patient. And perforated HAMN, of course, we'll have to consider for CRS and hypoc. And that's a repetition. See, HAMN after appendicectomy, as I said, it's already almost always considered as a high-grade tumor and go for CRS and HIPEC. And adenocarcinoma, of course, we consider CRS and HIPEC for the patient. And for right hemicolectomy and CRS, and because CRS, cytoreductive surgery and HIPEC doesn't mean that we should go for a right hemicolectomy also. In some of the tumors, some of the cases like LAMN with an advanced PCI, we go for, if the right colon is free, we can get away with the CRS and HIPEC alone. But CRS and HIPEC alone, along with right hemicolectomy is considered in mucinous adenocarcinomas of the perforated and non-perforated, and mucinous with adenocarcinomas of the any T-stage, right hemicolectomy along with CRS to be considered. These are the regimens. I'm not going to it. And even if there is mucin or carcinomatous peritoneum present, which are the condition we avoid as CRS and HIPEC. There is absolute contraindications. One is the extensive small bowel serosal involvement. It is absolutely contraindicated. And a mesenteric involving, the root of mesentery involvement is present. In such condition also CRS and HIPEC is avoided. And there are relative contraindications, as there are few factors by which that is, one is the age. All these are the relative contraindications: aggressive histology, the engagement of the liver hilum, the infiltration of the pancreas, ureteric obstruction, CRS requiring a total gastrectomy. All these conditions, in certain cases or in majority of the cases, we avoid a HIPEC. And for coming to the systemic therapy, there is no role for systemic therapy in low-grade mucinous tumors of the appendix. And for grade 2 and grade 3 mucinous tumors, and for mucinous tumors or high-grade tumors of the high-grade features with pseudomyxoma peritoneae, we can consider 5-fluorouracil-based regimen, same as in colorectal cases. And perioperative systemic therapy shows to be better than adjuvant treatment. And coming to the margin basis, what is the margin status after appendicectomy? Always we require a free margin or a negative margin, but if at all it comes as a positive margin, if the literature says there are evidences that for an LAMN even we can go for surveillance for low-grade mucinous tumors. For high-grade tumors and adenocarcinomas, of course, we have to revise the base. And the revision of the base can be either a partial cecectomy, stapling the cecum, that either if we suspect intraoperatively, it can be done during the first surgery itself, preserving the ileocecal valve, or it can be an ileocecectomy or a classical right hemicolectomy. So, concluding, pathology plays a major role in the treatment of appendiceal neoplasms, and appendicectomy alone is sufficient in margin-negative LAMN and without perforation and serrated adenomas or benign tumors. And HAMN, for practical purposes, it should be treated as a mucinous adenocarcinoma, and CRS HIPEC is an integral part of the management of the locally advanced or advanced appendiceal neoplasms. Thank you. I know it's a very huge topic, and I know I haven't done any justification to the topic because pathology itself is a huge topic. So I had to limit my talk for 20 minutes. Thank you.
Forum is open for discussion. Basically, this talk was kept basically for postgraduates. They are the one who are in and out doing appendicectomy. So my query is, what will be the warning signs when you see appendiceal neoplasm, or intraoperatively when they are doing, what should be taken care of, what should be looked, or what should not be done if you suspect a malignancy? If you can put it in a nutshell.
Just that's actually multiple things. I mean, preoperatively, anyway, we will be going with an CT scan. If any evidence of a mucocele, the caution starts there, because we have to do we can get away with an appendicectomy, lap or open, whatever. provided make sure that you don't spill the mucin into the abdomen. You can get it in a bag and this, take it out. Or intraoperatively, for an acute appendicitis, you are going in for a surgery. Intraoperatively, you have a suspicion that that can be a possibility of a malignancy can be there. It's always better to have a partial cecectomy as well. And second thing is that if any doubt that you have regarding the malignant chance of malignancy for the appendix, always evaluate the whole of the peritoneal cavity to see any mucin or any other tumor deposits. If anything is there, any tumor deposits or mucin deposits are there, it's better to stop there rather than doing an appendicectomy and doing it the other definitive procedure later. I think we can go for a definitive procedure at a single time.
Layman, where you said that appendicectomy alone is okay.
Yes, sir.
Perforated, even perforated.
Yes, sir.
But another slide you talked about CRS and high PEC.
Sir,
that is with the PCI is high.
Even in PCA less than 3 with an layman, you can consider CRS and HIPEC. And we have evidences that even surveillance is okay. If patient recurs, if at all the recurrence comes in the later stage, we can go in for a CRS and HIPEC.
The previous slide you said appendicectomy alone is okay.
Appendicectomy alone is okay, sir. But if it PCA is more than 3, then you will have to go for it.
Okay, thank you.
Shyam, nice presentation. I have a doubt. When you see patients with some surprise other than this type of adenocarcinoma of appendix, I have had an occasion. Probably Eunice may be remembering that patient. Patient underwent appendicectomy. The report came after 2 weeks. Appendicular adenocarcinoma. So whether to do hemicolectomy or not, that was the question. And patient underwent a re-evaluation and did not show anything. Okay. After 6 months again we did, nothing was seen. But after 4 years, this patient came with peritoneal dissemination and died. So we can't select patients individually without any recommendation. I think we have to go for a radical surgery if you have any disease other than this LAM. That is my request, because we don't know the prognosis of many of the appendicular neoplasm, because the number of cases of appendicular carcinoma, etc., are very rare. I have 2 patients. One patient actually evaluated for a sigmoid colon stricture. Actually, patient was having an appendicular neoplasm that was infiltrating into the sigmoid. But we did a radical surgery, right hemicolectomy, anterior resection, preserving that center part of colon, then resection of the bladder, ureter, ureteric anastomosis. I think it's almost 10 years now. Patient is having no issue, she is still alive. So some patients have a better prognosis, but we cannot select which is better, which is bad. I think it has to be an individualized approach.
That's true.
It has always wondered me why you should have such a long segment of colon resected. A right hemicolectomy to be done. Is it for the clearance of the nodal stations? Or?
Actually, in oncology, for that matter, any bowel organ resection depends upon the extent of the lymph nodal dissections. But I actually missed out one procedure called radical appendicectomy is an approved procedure in this thing. That is the removal of the appendix along with the lymph nodes up till the ileocolic vessel, up till the main vessel. So that is the one accepted.
Because you were mentioning about partial cecectomy and all.
Partial cecectomy.
That's why I was wondering. Should we remove so much of colon there? Really?
Radical appendicectomy is the now standard accepted procedure for the organ restricted tumors.
Thank you.
Thanks.
Thank you, Shyam. Is there any role for hemicolectomy while doing cytoreduction for achieving complete cytoreduction?
Yes, we can.
That is there. Since we know that there is no lymph nodal spread for LAMN.
Because
so probably
rather than the left colon, it's almost always the right colon is affected badly most of the time in mucinous tumors. Mucinous dissemination. So for completion, to get a completeness of this thing, right hemicolectomy is indicated.
For
Definitely we
cytoreduction.
can.
Previously, we used to do lap right hemicolectomies for positive margin even in LAMN. Now the consensus has changed. That's why. How often would you recommend imaging post-operative period after having done an appendectomy and the report came as LAMN, low grade?
The first imaging after will be 3 weeks after the procedure.
That will be a CT or?
If it is suspecting a mucinous tumors, always we go for an MRI. Or MRI, and if it is other tumors, we go for CT scan.
CT. Okay, thank you.
And I request Dr. Dilip to have his opinion on his expertise in the CRS and managing the PMB, especially pseudomyxoma peritoniae.
As Shyam told, have a introp, you see a mucinous neoplasm of the appendix, which is perforated. Then one thing you should not do is, don't do a right hemicolectomy, don't do a hysterectomy, because this will open up the retroperitoneal spaces and the mucin will get deposited in the retroperitoneal, and then you will not be able to do a good cytoreductive surgery later. Another thing is radical appendicectomy is a very important procedure. When you see a mucocele of the appendix, go for radical appendicectomy, wherein you take the appendix beyond the base, you take a sleeve or sliver of cecum, you remove the nodes along the ileocolic vessels, so you will get around 6 to 8 nodes will be sampled. You take the ligament of trees, you take the peritoneum as well as the peritoneum under the small bowel as well as the cecum. So this makes the radical appendicectomy. Also sample the mucin, because a pseudomyxoma peritoniae from a appendix is a different pathology. It may be LAM in the appendix, in the peritoneum it may be high grade, and it is classified as high grade if the peritoneum shows high grade features. So the sampling of mucin is also very important in these situations. So for a postgraduate, if you see a tumor in the appendix which is ruptured and there is mucin around, don't do a right hemicolectomy. And sometimes these tumors also has got ovarian cysts. So don't do a hysterectomy also, because that will open up the retroperitoneal spaces. The two things which are important. Yeah, it's also called ligament of trees near the appendix. So that has to be, there's a very good paper by Santiago Gonzalez and Sugar Baker, which has described this procedure of radical appendicectomy. And it's a very easy procedure. It can be done even laparoscopically. So if there is a suspicion, then radical appendicectomy. So that would be a curative option.
Thank you, sir. We'll have Dr. Sona is here. Can you come to the podium? She was a quiz master for the quiz. I didn't spot her. I request Rajan sir to hand over a small token of appreciation and gratitude from our side to Dr. Sona. She did an excellent work. It was a very innovative idea. It was a very good quiz. I request Dinesh sir, last time we were not yet able to distribute the certificate. I request Dinesh sir to, then I request Gopi sir to hand over the certificate to Dinesh sir for his last time talk. I request Dr. Ashwin. I request Dr. Ashwin to come. I request Alex sir to Sarvottam sir to hand over the certificate. I request KK Rajan sir to hand over memento to Dr. certificate to Dr. Nisamuddin. I request Pradhaban sir to hand over the certificate to Dr. Shyam Vikram. Actually, I have to bear 5 minutes for them because whatever demands I kept for the conducting the meeting, the entire Ashwini team was ready to do whatever I wanted. I requested them. The live streaming is there. They're ready to. It's around 130 crowd actually. Many are standing outside when there is no space. So, as a gratitude, to give 5 minutes for them. Basically, they have revamped their IHC panel. So to promote that only, they have sponsored the meeting. So they have entire set of IHC. So they will have a 5-minute talk on that. I request to finish it fast.
Good evening to all. I am Hari Krishnan. I have completed post-graduation in medical laboratory technology, and I am currently working as the application specialist of Ashwini Diagnostic Services. So first of all, a big thanks for giving us the opportunity to do this presentation. So Ashwini Diagnostic Services have been functioning since 1994, and in 2011 we got the NABL accreditation and became the first laboratory in North Kerala to achieve this. Now the main objective of our presentation is to inform you about the IHC markers as well as molecular oncology departments. So immunohistochemistry, as you all know, plays a significant role in the field of oncology. It helps you to know whether the cancer is spreading slowly or aggressively. It helps you to classify the cancer, and most importantly, it helps you to select the appropriate treatment for the cancer. So keeping all this significance in mind, we are now covering above 50 IHC markers, and all the procedures are monitored by our pathologists, Dr. P.C. Rajalakshmi, Dr. M. Hemachandran, Dr. Srija Sridharan, and Dr. Sandhya S. So now I will quickly mention the IHC markers which we are covering. First of all, under breast cancer panel, we are doing ER, PR, HER2, KI67, E-Catherine, P63 and CK56. Now under colorectal cancer, we are doing CDX2, CK20, cyclin D1, cytokeratin AE1, AE3, Vimentin, P53 and CK7. Now under gastrointestinal stromal tumor, we are doing DOG1, CD34 and CD117. Now under lymphoma panel, we are covering two B-cell lymphoma markers, BCL2 and BCL6, along with a numerous CD markers ranging from CD1A, CD3, so on to CD 68. Now on the lung cancer panel, we are covering TTF1, CK56, CK7, P53, P63 and calretinine. Now we are also doing panels for ovarian cancer, prostate cancer and renal cell carcinoma. Under smooth muscle tissue, we are doing rhabdomyosarcoma, smooth muscle tumor, mesothelioma and Ewing sarcoma. Under angiosarcoma, we are covering CD34, and in IgG4 related systemic diseases, we are doing IgG4. We are also covering synovial sarcoma, and the marker is TLE1. Under neuroendocrine tumors, we are doing synaptophysin, and under astrocytoma, we are covering GFAP. Now, under melanoma, we are doing HMB45 and S100, and under myeloma, we are doing CD138. Now, the price of single IHC marker is 1,200 rupees, and the reports will be ready by 3 to 7 days. And also, due to the increasing significance of breast cancer, we are covering 4 breast cancer markers, which are ER, PR, HER2 and Ki67 for 3,500 rupees instead of 4,800, and 3 breast cancer markers, which are ER, PR and HER2 for 3,000 rupees instead of 3,600 rupees. Now under molecular oncology, we are covering 4 important tests, and all the tests are monitored by our Dr. Sanish Babu. The first test is JAK2 V617F mutation. This test is used to qualitatively detect if V617F mutation is present on Janus kinase 2 gene of patients suspected with myeloproliferative disorders. And the method we use is real-time PCR. The sample type is EDTA whole blood, and the reports will be ready by 3 days. Now under next test is BCR-ABL quantitative PCR detection. It is used for quantitative detection of BCR-ABL infusion gene transcript, major, minor and micro in patients with CML, AML and ALL. Now the method is real-time PCR. Reports will be ready by 3 days, and the sample type is EDTA whole blood. Now next is EGFR mutation detection. It is used to detect if any mutation is present in the EGFR gene of lung cancer patients. Method used is real-time PCR. The sample type is tissue, and reports will be ready by 3 days. We will soon incorporate ALK ROS also along with this EGFR. And the final one is PML-RARA detection. It is used to qualitatively detect PML-RARA transcript genes in patients of acute promyelocytic leukemia. Here also the method is RT-PCR. The sample type is EDTA whole blood, and the TAT is 3 days. So once again, I am thanking you. I hope I didn't took too much of your time, and Ashwini will still continue provide its best service as it has been doing for past 30 years. Thank you so much.
I am not extending the vote of thanks. I sincerely appreciate Ashwini for their efforts. I think their markers rates are actually 3,000 is okay, and I request the management of Ashwini to give more discount for patients from medical college if at all there is any issues. Probably our charges is 500. So if something close to 500 is there, we can probably give a better thing. And thank you Ashwini, entire team of Ashwini for sponsoring the meeting. Thank you very much. I think the meeting can be adjourned. The fellowship and food is arranged in the back.